Hello, my name is Andreas Rillig from the University Heart and Vascular Center in Hamburg, Germany. I am a cardiac electrophysiologist and an ablationist, and I'm dealing with arrhythmias of all kinds, atrial and ventricular arrhythmias. I would like to talk about the sub-analysis of the EAST-AFNET trial, a sub-analysis which is based on the stratification of patients in cardiovascular comorbidities, whether they have a high cardiovascular comorbidity burden, which is finally based on a CHA2DS2-VASc score of 4 or higher, as compared to patients with a lower comorbidity burden, CHA2DS2-VASc score below 4. Yeah, finally, we did a pre-specified sub-analysis per protocol of the EAST-AFNET trial. So the EAST-AFNET trial was a trial which randomized 2,789 patients to either early rhythm control or usual care. And what the baseline characteristics of these patients were that they had a CHA2DS2-VASc score approximating of 2 or higher. And all these patients had early diagnosed atrial fibrillation. That means atrial fibrillation diagnosed within 1 year. And this pre-specified sub-analysis was stratifying these patients of the EAST-AFNET trial, all 2,789 patients, in patients with a high comorbidity burden, cardiovascular comorbidity burden of a cutoff of CHA2DS2-VASc score of 4 or higher. And we found that we had 1,093 patients with a CHA2DS2-VASc score of 4 and higher, as compared to all the other patients which were with a CHA2DS2-VASc score below 4. The study design was finally based on the EAST-AFNET main trial. That means randomization of 2,789 patients. They were randomized to early rhythm control as compared to usual care. One major criterion was a CHA2DS2-VASc score of 2 or higher as an inclusion criterion for these patients, and as well as an early diagnosis of atrial fibrillation. That means atrial fibrillation diagnosis within 1 year. So this was a pre-specified analysis, which was pre-specified per protocol. That means the cutoff of CHA2DS2-VASc score of 4 was not randomly chosen. It was pre-specified before the analysis has taken place. The main findings of our sub-analysis were that patients with a CHA2DS2-VASc score below 4 had no significant benefit when they were randomized to early rhythm control. So there was no reduction of the primary endpoint of the trial. The primary endpoint of the EAST-AFNET trial was the same as for the sub-analysis, and the primary efficacy endpoint was the composite endpoint of cardiovascular death, stroke, or hospitalization with worsening of heart failure or acute coronary syndrome. Patients with a CHA2DS2-VASc score below 4 did not benefit regarding this primary endpoint whenever they were treated with early rhythm control. No significant difference. However, what we could see in the patients with a CHA2DS2-VASc score of 4 or higher is that early rhythm control significantly reduced the composite primary outcome, which was the composite, as I mentioned before, cardiovascular death, stroke, or hospitalization with worsening of heart failure or acute coronary syndrome. So there was a significant benefit also visualized with the interactive p-value, which was significant. Another important key finding is safety. So we had also a safety endpoint, which was slightly different in these two groups. We had no significant difference in the primary safety endpoint when we were looking at patients with early rhythm control in the CHA2DS2-VASc in the high comorbidity burden group. That means patients with a CHA2DS2-VASc score of 4 or higher did not have more safety events, but they had, or maybe we can cut that on. So we had, what we could see is that patients randomized to early rhythm control in the higher comorbidity burden group, CHA2DS2-VASc score of 4 or higher, had a trend to less primary safety events, but this was not significant. But finally, we had the finding that they did benefit regarding the primary efficacy outcome, and there were no safety signals such as increase of safety events. However, when we looked at the patient group with a CHA2DS2-VASc score below 4, these were the patients which did not have a benefit regarding the primary outcome. We could see that there was a significant increase when patients were treated with early rhythm control regarding the primary safety outcome. An important message is that the primary safety outcome in this group was not driven by lethal or by life-threatening events. It was more or less drug-induced bradycardia, it was rehospitalization due to AF rehospitalization or due to AF recurrence, and it was side effects of the treatment of the rhythm control therapy. So no life-threatening events. However, When we put that together, it means no benefit regarding the primary outcome, but more or less some safety issues we should consider. Finally, our findings do not speak against rhythm control treatment of patients with a lower comorbidity burden, in particular if they are highly symptomatic, because we know that rhythm control, also in particular catheter ablation, can significantly reduce symptoms in these patients. However, regarding outcomes with cardiovascular death, stroke, and hospitalization of heart failure and acute coronary syndrome is not reduced as far as we learned from this sub-analysis. So finally, our sub-analysis has shown that patients with a high comorbidity burden benefit most when they are treated with early rhythm control therapy with regards to reduction of the primary outcome. However, this is a sub-analysis. Even if it was pre-specified, this means that the findings are hypothesis generating. We nevertheless believe that patients with a high comorbidity burden and early diagnosed AF should be treated with early rhythm control. However, we also would call for studies, that means for dedicated trials addressing in specific this issue. And as long as we do not have trials reporting on outcomes in larger patient populations, we believe that we should consider the main findings of the EAST-AFNET 4 trial in context with this sub-analysis. The main message is that patients with early diagnosed atrial fibrillation diagnosed within 12 months, and the high comorbidity burden, that means a CHA2DS2-VASc score of 4 or higher, had a significant benefit regarding the primary outcome, which was the composite of cardiovascular death, stroke, or hospitalization with worsening of heart failure or acute coronary syndrome when they were treated with early rhythm control. In contrast to that, patients with a CHA2DS2-VASc score below 4 with a lower comorbidity burden did not benefit regarding a reduction of the primary outcome when they were treated with early rhythm control. However, they had more safety events which were not life-threatening, but more or less based on bradycardia due to atrial fibrillation medication, side effects of atrial fibrillation medication, and hospitalizations due to recurrence of atrial fibrillation. We finally believe that patients with a high comorbidity burden, based on our sub-analysis, should be preferentially be treated with early rhythm control. And we need more dedicated trials which report on data specifically addressing this issue. And as long as we do not have these trials reporting on this, we would consider the main findings of the EAST-AFNET 4 trial in context with this sub-analysis.